already been given at least 2 lectures on pharmacokinetics, so I'm sure you already have an idea of what it is. In essence, pharmacokinetics is what the body does to the drugs. And what it does to the drugs, it absorbs it, distributes it, metabolizes it, and later on excrete it. So in this dose effect continuum, where do you find your pharmacodynamics and pharmacokinetics? For example, after giving 1 dose of the drug is first absorbed and then distributed to the different body compartments. The most important compartment is where the drug is expected to have an effect. In the case of pneumonia, this is your lungs. For UTI or urinary tract infection, it's in the urinary system. Now, as the drug takes its action or exerts its effects, it is also being metabolized and eventually excreted. As the drug is being excreted, that's also the point where the effect of the drug starts to wane, mainly because the concentration of the drug slowly decreases as it is being excreted. So in essence, you cannot separate pharmacokinetics from pharmacodynamics. They work hand in hand, but you can distinguish one from the other. So why is pharmacodynamics important? 1, it provides basis for both the rational and therapeutic use of the drug. Why do you use drug for? It is because of its mechanism of action. It also provides basis for the design of new and superior therapeutic agents. Like, for example, if you want to make and improve cephalosporin, the latest cephalosporin that we have in the market is actually already in the 5th generation. So if you want to design a 6th generation cephalosporin, which is much better than the present one, then you need the pharmacodynamic aspect of this latest cephalosporin to be able to design a better one. And of course, you need it for research. So how does a drug work? This is the mechanism of action of the drug, or how the drug is able to produce its effect. Majority of the drugs produce their effect by interacting with a target molecule, and this target molecule is usually a protein. Most of these are your physiological receptors. On the other hand, a handful of drugs work without the need of receptors, and these are what we call standalone drugs. So example of drugs that act without being bound to any of the tissue constituents or receptors are the following. Number 1, you have your mannitol. Mannitol is an osmotic diuretic, so it has an osmotic activity. In itself, it can attract water molecules so that once attached to it, it can bring these water molecules down and excrete them through the urine. So that's how an osmotic diuretic works, like mannitol. You also have your activated charcoal, which has an adsorptive property. Activated charcoal is used for poisoning. So you give it orally to the person preferably within 30 minutes to 1 hour after the intake of the poison. So the activated charcoal will bind to the poison. It will absorb the poison and then bring it down through the gastrointestinal tract and excrete it through the anus, because activated charcoal is non-absorbable. You also have your antacids. Antacids directly neutralize gastric hydrochloric acid. Cholestyramine works similar to activated charcoal. It also binds to bile acids and cholesterol in the gastrointestinal tract, and it's also non-absorbable in the gastrointestinal tract, so it brings with it the bound bile acids and cholesterol. That's why it can also help in lowering serum cholesterol. Para-aminobenzoic acid, or PABA, works by absorbing the UV rays. No? So you find PABA usually in lotions, lotion that will protect you from the heat of the sun. Chelating agents like ETA and dimercaprol, they are absorbed in the bloodstream, and in the bloodstream, it also binds with the metals, heavy metals, because if you have a lot of heavy metals in your body, you'll be poisoned by it. So this is how chelating agents work. There are also drugs that work on receptors of microorganisms. There are also drugs that work on receptors of microorganisms. Example of these are your antimicrobial agents or antibiotics. So in particular, you have cotrimoxazole, which is a combination of trimethoprim plus sulfamethoxazole. It inhibits folic acid synthesis in the bacteria. By competitively inhibiting the enzyme dihydropteroate synthase, that's for your sulfonamide, and the hydrofolate or the hydrofolic acid reductase enzyme by your trimethoprim. Our body also needs folic acid, but its activation is not affected by cotrimoxazole. Why? Because we belong to the higher order of organisms. Our physiology is more highly complex than the bacteria. That it needs more than 100,000 times the amount of cotrimoxazole that can kill the bacteria or can affect the folic acid synthesis of the bacteria before our own enzyme system can be inhibited. Although there are still cases that the intake of cotrimoxazole can worsen folic acid deficiency among humans. And you know that when folic acid is deficient, you can develop, or you may develop, megaloblastic anemia. But it's relatively rare. There are other new unconventional mechanisms of action of drugs. An example is your atalaran. Atalaran is a drug that modifies certain specific genes. In particular, it's useful for Duchenne muscular dystrophy, which is a genetic problem where a nonsense mutation causes a premature introduction of a stop codon in the mRNA gene transcript. So what atalaran does is it acts on the ribosome to override the premature stop codon, allowing the ribosome to read through, thus producing normal protein. particular, this protein is we call it dystrophin. This causes the increased production of this functional dystrophin protein and causes an improvement in the muscular function of patients with Duchenne muscular dystrophy. So more of these types of drugs will come out in the future. So this is an area where research is still very much needed. Another new unconventional mechanism of action of drugs is the use of nano drugs. So when you say nano, these are very, very small structure of the drugs. And so if you're familiar with micro, multiply that by 9, so to the 9th degree, smaller, and that's your nano drug. So because it's very, very small, the capacity of the drug to penetrate into the different compartments of the body is very high. So that's why if you use nano drugs, you don't need to use the usual dose. You only need a small dose because penetration is very good. But toxicity is still a problem with nano drugs. That's also an area where research is still very much needed. It's still very new. So now let's go to the main mechanism and how drugs work. So most drugs work by interacting with endogenous proteins in our body. And these proteins are classified as physiological receptors. So what is a receptor? It is a macromolecular component of a cell with which a drug interacts to produce a response. There are many kinds of receptors. Number one, there are drugs that work on receptors that affect concentration of endogenous ligands. Example of endogenous ligands are your norepinephrine, epinephrine, arachidonic acid. So these types of drugs alter the synthesis, storage, release, transport, and metabolism of these ligands, these neurotransmitters, hormones, or mediators. Example of these drugs are the following: cocaine, blocks norepinephrine uptake or reuptake in the synaptic cleft. Amphetamine promotes norepinephrine release, whereas NSAIDs block the cyclooxygenase pathway, so it makes it anti-inflammatory. Okay, there are also drugs that act on receptors associated with extracellular processes. Under these are the drugs that control thrombosis, so these are antithrombotic agents, anti-inflammatory agents. Some drugs also act on receptors utilized by anti-infective agents. So we discussed this in the previous slides already. There are also drugs, of course, that act on receptors that regulate the ionic milieu. Receptors for these drugs are ion pumps and transporters expressed only in specialized cells of the kidney and GIT. An example of these are your potassium ATPase of the parietal cells. And of course, you have the intracellular pathways activated by the different physiological receptors, which is otherwise known as your signal transduction pathways. So if you're familiar with this, the structural and functional families of your physiological receptors. So this is summarized in table 3.1, page 40 of your book. So study this table very well. So in here, you have the different structure family, PCR, ion channels, transmembrane enzymes and non-enzymes, nuclear receptors, and the intracellular enzymes. We also have under each structure family, the functional family, the physiological ligands, examples of effectors and transducers, and examples of the drugs. So we will go back to this slide later. So if you want to review the physiology and biochemistry of these physiological receptors, you can visit this link. It's just a very short video. So let's now take a look at how the drugs interact with the receptors. So these are the terms that describe drug-receptor interaction. Number one, we have an agonist. So if a drug works as an agonist, it is an agent that activates a receptor to produce an effect similar to that of the physiological signal molecule, which is otherwise known as your physiological ligand molecule. Examples of these are your muscarine and nicotine. Muscarine for muscarinic receptors, nicotine for nicotinic receptors. Among the agonists, you have what we call also a primary agonist. So for a primary agonist, this is a drug that binds to the same recognition site as the endogenous agonist. An example of this is salbutamol. Salbutamol is a primary agonist of the beta-2 receptor of the sympathetic nervous system. We also have what we call allosteric agonists. Allosteric agonists are drugs that bind to a different region on the receptors. For example, in this case, we have this GABA A receptor complex. And you can see that there is this GABA sites here. These are the receptors for GABA. And you know that GABA is gamma aminobutyric acid. It's a physiological ligand. It's a neurotransmitter. The drug here is benzodiazepine. That's the BCD there. And you see that your benzodiazepine has a different site. No? So its receptor has a different site compared to your GABA. Okay, and that site is called an allosteric site. So we consider benzodiazepine as an allosteric agonist. So it binds to a site different from GABA in this case. However, it's still in the same complex, GABA A receptor complex. So what does allosteric agonist do? Drugs that bind to allosteric sites could potentiate the effect of the primary agonist. For example, in our example where benzodiazepine is or sits in the allosteric site beside GABA, it works as an allosteric agonist. So it potentiates, actually the proper word there is modulate. So the essence is, the effect is it enhances the effect of GABA. And what is the effect of GABA? It's inhibitory. See, it's an inhibitory neurotransmitter. So the effect of your benzodiazepine is it enhances the effect of GABA. So actually, the result is potentiation, what we call partial agonists. Partial agonist is an agent which activates a receptor to produce submaximal effect but antagonizes the action of a full agonist. Example here is an opioid. This figure just shows you the level of response to the different types of agonists. So you have there the full agonist, of course, and it results to the highest response, followed by a partial agonist. This in the middle is that part where there is competitive antagonism. No agonist is present. And of course, the effect of the inverse agonist is opposite to the full agonist. If we have agonists, we also have antagonists. So there are also drugs that work as antagonists. So these are the drugs that block or reduce the action of an agonist. So the terms here that you need to remember are the following: syntopic interaction, wherein the drug competes with the agonist for the same site on the receptor. So this is also similar to competitive antagonism or competitive antagonist. Allosteric antagonism, so we already discussed allosteric reaction and binding. So the drug interacts with other sites on the receptor. Chemical antagonism. In chemical antagonism, the drug combines with the agonist. And then functional antagonism is when the drug indirectly inhibits the cellular effect of the antagonist. So going back to this table, stimulation of the beta-adrenergic receptors, that's the first line here, is carried out through the GPCR structural family. So the example, the drugs that are given here as examples are your dobutamine and your propranolol. So the butamine is a beta-1 adrenergic agonist. So it works as a full agonist. So it stimulates beta-1 receptors, sits in the same receptor as the physiological ligands, which are your norepinephrine, epi. So in the presence of the butamine, beta-1 receptor is stimulated and couples with GS, resulting to increase in intracellular cyclic AMP activity, resulting to heart muscle contraction. This is what we call positive inotropic effect. That's why the butamine is known as an inotrope. On the other hand, propranolol is a non-specific beta-adrenergic antagonist, which slows down the heart rate and also causes smooth muscle contraction because it's non-specific. So it doesn't antagonize only the beta-1 receptor, but also the beta-2 receptors. That's why it has several actions. Anyway, let's take a look also at competitive versus non-competitive antagonism. So for competitive, you have here an antagonist that is chemically similar to the agonist and competes with it and binds the same site, disallowing the agonist molecules The binding is usually reversible. So how do you reverse the binding? By just increasing the amount of the agonist, you can already overcome the block caused by the competitive antagonist. So the same maximal response can be attained by just increasing the dose of the agonist, meaning that the antagonism is surmountable. What about the non-competitive? Non-competitive antagonist is chemically unrelated to the agonist. It binds to a different allosteric site, altering the receptor, and the effect or the change is irreversible. So even increasing the agonist concentration will not reverse the block. So we call it unsurmountable antagonism. So other pharmacodynamic concepts that you need to understand, the word affinity. Affinity is binding. No? So when we call a drug as having a high affinity, it means that it can bind to a greater number of receptors even at low concentration. What about potency? So potency is when two drugs produce equivalent response. The drug whose response curve lies to the left of the other is more potent. So in this case, comparing drug X and drug Y, the concentration of the drug that is needed to produce half the maximal effect is lower with drug X compared to drug Y. Thus, drug X is more potent. So you're looking at the EC50. So EC50 is the concentration producing a half maximal effect. Another term to understand is efficacy. So efficacy is the capacity of a drug to activate a receptor and generate a response. So full agonists have high efficacy. So you expect a full response. That's your drug X. Partial agonist, low efficacy. So may not give you a full response at any dose, and that's your drug Y. Now let's talk about pharmacodynamic variability. This is the response to the drug among individuals. So for example, if you and your best friend, or maybe you and your sister or brother take the same drug at the same dose at the same time for the same reason, do you think that the two of you will respond to that drug exactly the same way? Maybe not, or most often, you will not have the same exact response because there are a lot of factors that affects pharmacodynamic variability or that affects our response to the drug. Okay, and these factors are, for example, the disease itself, the age of the patient, the previous drug administered, the presence of another drug given concurrently with the drug that you want to study, and depends also on the concentration of receptors. So the median effective dose for ED50 is the dose of drug that is required to produce a specified effect in 50% of the population. So the median effective dose of one person may not be the median effective dose of another person. So that's why it's a range. We also have this pharmacodynamic term, median lethal dose, or LD50, which is the dose of the drug required to cause death in 50% of the population. Of course, we do this in experimental animals. We don't check the lethal dose, the LD50 among humans. What about the term therapeutic index? So therapeutic index is LD50 divided by your ED50. It's the ratio between the two. And this reflects how selective the drug is in producing its desired effect versus its adverse effect. So a drug with a wide therapeutic index is a safer drug when compared to a drug with narrow therapeutic index. So the therapeutic window is the range of steady state concentrations of the drug that provides therapeutic efficacy with minimal toxicity or no toxicity at all. It's the range at which the likelihood of efficacy is high and the probability of adverse effect is low. So this is what we want. We want to work within the therapeutic window. So we don't want to go beyond the therapeutic window, because if you go beyond the therapeutic window, so you give a very high dose of the drug, then you expect more adverse effects. Of course, you want to maximize the effect without the adverse effect. So factors that modify drug action. So from the time you take the dose of the drug, there are already a lot of factors that can affect the drug action, the action of the drug. So it's a mixture of pharmacodynamics and pharmacokinetic factors. So it already includes medication errors by the giver of the drug, patient compliance, whether the patient will take the drug or not, or whether the patient takes the drug at the specified time or not. There are also these pharmacokinetic factors, no? Your ADME. Other than that, you also have pharmacodynamic factors, so physiological variables, pathological factors, genetic factors, interaction with other drugs, drug-drug interactions, etc. So many factors that can actually modify the action of the drug. Okay, so all these things you need to consider from the time that the drug is taken in or administered to the concentration of the drug in the site where it is needed before it can have its effect. Okay, what about drug interactions and combination therapy? So when do we do combination therapy? When do we use more than one drug? Number one, if we want to achieve an additive or synergistic effect. So, for example, you have a patient with severe asthma attack in the emergency room. Of course, you start off by giving your salbutamol nebulization. After one dose of salbutamol nebulization, it seems that there's not much of an effect that you see. So you want to add some more because you want to help the patient. what you can do is you can add an ipratropium bromide. So an ipratropium bromide works as an anticholinergic. Your salbutamol works as a beta-2 agonist. So these two drugs, they have different mechanism of actions. However, the effect is similar, and that is bronchodilation. That's one. If you want to treat multiple conditions, then you may use combination therapy. But when you do combination, you expect that there can be marked alterations in the effects of some drugs. So there can be drug interactions, and drug interactions can affect the pharmacokinetic profile of the second drug. Or it can also affect or disrupt the pharmacodynamic profile of the drug that's being modified. So we call it the second drug. So that's the drug that is affected by the first drug. Okay, so interactions like enzyme induction, enzyme inhibition, you can expect that in if you do combination therapy. So in summary, the effects of drugs in the body depends on their interactions with the receptors. No? So it can be a stimulating action, it can be depressing or blocking or exchanging. There can be direct beneficial chemical reaction or direct harmful chemical reaction. So the interactions may result to some desired effects. These are the following desired effects, or it can result undesirable effects like these. So it can result to salivation, it can result to adverse effects, okay, and even physiological damage, abnormal point conditions, etc. Okay, so generally, the effects of the drugs can be attributable to their interaction with the receptors, which can result to a conformational change or absence of these changes, which can result to an effect. Okay, so that's the essence of pharmacodynamics. I think that's the last slide. Thank you for your attention.